This lecture is about the physical examination of hip. So in physical examination, first one is the observation. So in observation, we analyze the gait. First one is the lunge. A lunge to one side during a stance phase suggests that there is a hip abductor weakness. In lurching gait, there will be a weakness of a unilateral abductor muscle. Next is a excessive lordosis during a stance phase, which may suggest that there is a contracture on the side of a stance leg. What happens during a stance phase is that there may be a backward lurch, which may suggest that there is a hip extensor weakness on the side of a stance leg and there is a hip flexor weakness on the side of a swing leg. Another is the inclination of a pelvis to one side during a gait and a heel strike on the side of the hip. This may result in the adduction contracture. Next, we go for the functional activities. That there will be a loss of hip motion if there's a difficulty in wearing shoes or socks or any slacks. The patient may sacral sit to compensate for the hip lack of the hip flexion. There may be a difficult for the forward bending to touch the toes and cross legs if there is a hip pain. And next is a tender bug sign. What happens in the tender bug sign is that, like for example, if there is a right side weakness, so on that side there will be a hip hike. So there on that side there will be the abductor weakness. Gluteus medius and gluteus minimus on that side will be weak. Next is to check the balance and the reach test. In balance in the reach test, a patient will stand on a unilateral stance on the involved extremity and he will reach in different directions with the uninvolved extremity. And again, a patient will stand on a unilateral stand and will reach with the uninvolved extremity. Next is a unilateral stance on the involved extremity. Next, we perform the squatting and a sitting on the heels. And next will be a rotation on a trunk while standing on a one leg, which will differentiate your lumbar and a hip pain. And next one is the weight bearing to the right and the left leg is even. So you have to check a general posture of her body. Note whether that there is a equal even weight bearing on the left and the right leg, that there should not be any asymmetry. Next is to check the inspection skin, like there is any surgical scars, any scratches present on the skin. Next, to check the soft tissue, observe the muscle bulk and the muscle tone of the patient. Just compare the right and the left side, that there is any atrophy present or not, that there is any type of muscle wasting. Next is the bony structure and the alignment. In this, you have to check the heights of an irregular tubercle, medial malleoli, fibular heads, popliteal and gluteal folds, crater to candor, and the most important, interior superior iliac spine and the posterior superior iliac spine and the iliac crest. So you have to check whether interior superior iliac spine and the posterior superior iliac spine of both the sides are on the same level or not. Like if interior superior and a posterior superior iliac spine of one side are lower as compared to the other side, there is a possibility that there is a sacroiliac torsion rather than the hip pain. Like if ASIS and a PSIS of one side are lower, so there may be a coxa varum on the lower side and a coxa valgum on the high side. There can be a shortened femoral neck on the lower side and a cartilaginous narrowing from a hip degeneration on the lower side. The most important is usually the coxa varum and a hip degeneration are the two most common. The next is to check the leg length discrepancy. Measure the ASIS to medial malleolus of the same side. To check the lateral discrepancy, what you check is to check the level of ASIS to the level of a medial malleolus of the same side. Next, to move towards the active movements. In active movements, the patient will perform the flexion, extension, abduction, adduction, internal and the external rotation at the hip. So what the examiners check is the quality of movement, check the range of movement, and check that there is any resistance present throughout the range or not, or at the end of the range, or to check the behavior of a pain through the range or at the end of the range. A patient will perform all these movements. Next is to check the passive movement. So in passive movements, all flexion, extension, abduction, and adduction will be performed, and you have to check that there is a capsular pattern present or not, and check the end field too. Like if the capsular pattern of restriction is present, so there will be a marked limitation of the internal rotation and abduction. There will be a moderate limitation of flexion and extension, and some limitation of external rotation and adduction. And also check the end field in the passive movement as well. Next is to check the joint play movement. So in joint play movement, you will apply the distraction, inferior glide, posterior glide, interior glide, and you will check that this movement is a normal, whether it's hypermobile, hypomobile. Check the amplitude and as well as the quality of movement through the range, and presence of any resistance throughout the range, or a behavior of pain throughout the range. Next is the mobilization with movement. So this will tell you whether the pain is of mechanical joint problem or not. Like what happened in this, the patient will be supine and stabilize the pelvis. Apply the lateral guide through the belt to the femur, and patient moves hip into medial rotation or a flexion. So, if there is an increase in a range of movement, or there is a reduction in the pain with the active flexion or the medial rotation of a hip, this is a positive sign, which may indicate a mechanical joint problem. Next is a muscle test. So in muscle test, there are different things to discuss. The first one is a isometric movement, next is a muscle strength, and next is a muscle control. What happens in the resistant isometric movement, that there will be no motion at the joint. So first one is to check a flexion. What happened in the flexion? A patient will be supine and you will apply the resistance above the knee. If there is a painful weakness, may indicate that there is a psoas tendinitis, and if there is a painless weakness, it may indicate that there is a rupture of a psoas muscle, or there may be a L2 nerve root lesion. Next is to perform the extension, which will be again in the supine position. Apply resistance at the heel, and if there is a pain, it may indicate that there is a lesion in the origin of a hamstring muscle. Then perform the adduction. If there's a pain, lesion of adductors may be suggested, and apply then abduction. If there's a painful weakness, it may caused by the gluteus medius tendinitis. Then perform the internal and the external rotation and provide the resistance at the ankle. There may be a chance of the gluteus bursitis. Next is to check the muscle strength. So in muscle strength, you will check the strength of all the muscles, flexors, abductors, adductors, medial, and the lateral rotators. Next is to check the muscle control. So in muscle control, what you will do is to observe the posture, is to check the quality of motion and palpate the muscle activity. you have to check the firing pattern of a muscle. There is a sequence with every action, like which muscle will activate first and which muscle will follow that activation. So in this first in her examination of the hip, first you will check the hip abduction assessment. So in hip abduction assessment, the patient lies on the contralateral side with the bottom knee flexed and the top leg will be fully extended. The examiner then observes and palpates the firing pattern, which will shows that the gluteus medius will fire first, which will be followed by the tensor fascia lata. Like this is normal, but if there is any lesion, there is any abnormality, so what will happen? The tensor fascia lata will fire first as compared to gluteus medius. Next is a prone hip extension test. So what happened in the prone hip extension test? The patient lies prone in prone position and they attempt to raise the leg into extension with the knee held in extension as well. So what is the sequence is that hamstring and the gluteus maximal will fire first, then followed by the contralateral lumbar paraspinalis and followed by then ipsilateral paraspinalis muscle. And you use a palpation as well to confirm. But if this is negative, it means the paraspinous muscle will fire first as compared to a gluteus maximus muscle. So the firing pattern of a hip extension is changed.